Thank you. Thank you. Boy, you're hanging in there. You doing all right? All right. Hopefully you got up and walked around, got the blood pumping a little bit. You're good? Okay. So we're excited about this panel. Paul, even as you're sitting down, I just need to thank you. Thank you, thank you. Thank you for inviting us, the Illumination Foundation, of course. And Lisa Marsh-Ryerson had to leave, actually for a family matter, I'll just say that. But I just, in her absence, want to thank her. I think she did a fabulous job kicking us off. We're very proud of Lisa. Thank you. And I also want to thank my colleagues at the Center to Champion Nursing in America. You can see we're sponsored, well, you could see on the other one that we had the privilege of co-sponsoring this event, so thank you for that. And I've just really learned so much today, different perspectives. I'm not an expert in homelessness, so I learned a lot, and I plan on using it, so thank you for all of that. And what I wanted to do was just a little bit of a frame for the panel that we're going to be hearing. And I wanted to start with the National Academy of Medicine report on the future of nursing, because it sets a framework. It's all about having nurses step up and help lead health equity, advancing health equity. The whole report, it's like 600 pages. I reread it on the plane coming here again because it was released last year, so I was reading it again. And one thing that really stuck with me, which I think is very relevant to this group, is when you think about social determinants of health, you can think about it as social needs, like meeting social needs, generally of individuals, and you can think about it as meeting systems levels, policy, how do you change it? And throughout these panels, I've been hearing that. You know, you can set up tents and give food out 3 times a week. That was one of the statements. But that doesn't really address the problem of homelessness. You really have to go deeper into policy. So I wanted to think about that, and I was thinking about my own journey into policy. So I'm a nurse, and nurses are generally, it's not going to, you've had a lot of nurses. My apologies to social workers and others who are very engaged in all of this work, but we do have a lot of nurses here, and we're very proud of that. But in general, and I hope this is changing, when I was a student, policy was not on the curriculum, I'll put it that way, right? It's, how to take care of people. But I was really fortunate to be in a new program that was called Trenton State College. It's now College of New Jersey, in Trenton, New Jersey. And the faculty were young, vivacious folks that believed what the dean of Johns Hopkins must have said, because that was said earlier, that people are everywhere, and therefore nurses need to be everywhere. Do you remember that this morning? That was a great quote. Because, yes, we went into hospitals. We did our hospital training. But by the way, we did not wear white uniforms. We looked like airline attendants. We had like navy blue, either pants or a skirt, and an apron that fitted over it, because we were not to belong to the hospital. We were visiting the hospital, in a sense, because people don't live in hospitals. And that was their philosophy. And so our clinical experiences included like going to military bases, Fort Dix, and it also included going to prisons. I was a little scared. It was Trenton Prison, which is a really tough place, but they were fearless. They brought us everywhere, and literally park benches, and Alcoholics Anonymous, and Al-Anon. So all of that, you can imagine, leads you into social determinants of health, right? They didn't call it that. I don't think we called it that at the time. But they were really focused on following, when we were in the hospital, following patients home. Not through a home health agency. It could be that. But I don't know how they did this legally, frankly. I don't know how they did it, but we were able to follow patients home. So I had this patient, a mother, who was having her 4th child, and so I was first with the mother, and then the child had cardiac issues. So then I was visiting. Of course, I wasn't taking care of anybody. I was just talking to them. Really, we didn't really do a lot. This is early in my education. But they really wanted to keep following the family. It was very big into family. And it turns out this family were Mennonite religion, so I had to study, what does that mean? What is their meaning around that? And the husband lost his job while I was taking care of them, and he was illiterate. So it was hard for him to find a job. Well, my faculty decided that they would help me with this whole family. What did I know? I mean, I was like 18. What did I know how to take care of this? Long story short, we wound up having this husband, the father, in training literacy programs and got him a job at Trenton State. It was amazing. That's what made me want to be a community health nurse. It's like, this is it. I just loved it. And I can't tell you, this faculty was just fantastic. So there I go, I'm a community health nurse visiting people in inner city Newark. Anyone know Newark, New Jersey? Okay, the Jersey people do. so you would go in and be greeted very graciously. This is a very impoverished area, particularly at this time, very impoverished. And, it was kind of overwhelming because I didn't live in inner city Newark, but I was there to usually I think this one particular patient, it was to give an insulin injection and teach her how to do that. But you couldn't help notice that she didn't have any food in the house. I'm looking, is she eating the right food? And I asked if I could open the refrigerator. There wasn't much. Oh, because I had to put the insulin in the refrigerator. That's why. So, okay, so I'll learn. At that time, they were called food stamps. So how do you get someone on food stamps, right? And she needed to get to the doctor to check out the ulcers on her leg. She had no transportation. So how do you get transportation? Sounding like social determinants, right? Except that it was all about her needs. So I'm taking care of somebody's needs. I'm not changing the system. Okay, that's early on in my career. Then I went, it sort of woke me up though. I also had one patient I could get orthopedic shoes ordered. And I was all excited. I went to see another patient, I thought, I could get them orthopedic shoes. They need orthopedic shoes too, right? No, couldn't get it. My supervisor had to tell me to look at the bottom of the chart for the little square that said payment. And that's when I learned about Blue Cross, Medicare, Medicaid, VA, fee-for-service, blah, 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 and realized that I couldn't be the nurse I wanted to be depending on that box. So that was, wow, I got to learn about this. How do you fix that? Don't know how to do that, right? So I had already been a member of the State Nurses Association. And in the meantime, I go off to get my master's degree at the University of Cincinnati. And there, had to do a project. This is early days before infants were not in car seats. Okay, you could. My sister had one. And I was like, we got to get these babies in car seats, right? This is my public health thing. So I did this whole study of how to teach mothers about infant car safety, got my graduate degree, go back to New Jersey, and I'm like, wow, this is really good. I got invited to give a presentation in Chicago by the National Traffic Highway Safety Administration. Woo, first business trip, I'm all excited. I walk in the room, they said, we're so glad you're here. We're so glad there's a nurse in this room. I'm like, wow, that's great, because they're the problem. What? They're the problem? Yes, because we have all this research that it's really important, but the nurse brings the mother down, carries the baby, and says, I have to put the baby in your arms. It's the law. Now, I don't know if that was really true, but that's what they said, right? So what we really need are laws. We need laws to mandate that infants have to be in car seats. So that was my first experience. I went back to New Jersey, to the State Nurses Association, and said, we got to pass a law because we got to make sure that nurses are viewed in the way they should be, protecting infants. We have to do that. So the worst place you can be is in your mother's arms in the front seat, worse, right? So we got to change that. So I started learning about legislation. I was doing other things in my career, and hospice started up big time. You know hospice, right? So that's a policy. Except the nurses that were hospice nurses said to me, not just to me, but to others, we work with people to stay in their homes. They get their pain medication. They're ready. They're not going to call the hospital. They're going to die at home. And then the person dies at home. And then we have to wait for the medical examiner to come and pronounce death. And it can take 24 hours. And in the meantime, the family is frantic because they don't know what to do now, right? So my next thing was to get a law in New Jersey. It was, I think, the first or second in the country to have nurses pronounce death. And the legislators were like, I don't know if I want that. I'm not sure about that. So we made sure it was only in nursing homes, home care. We sort of had an agreement. And there was one legislator, by the way, who said, no, can't have that. What if I'm in a car accident and some nurse decides I'm dead and I'm not? I said, well, we'll get you a medical alert badge that says only cardiac surgeons can pronounce you dead. And I got him that, and he said, okay, I'll vote for the bill. So what I'm saying is that as a nurse, and I'm sure there are others in the room, it's taking care of individual needs. That's big. I don't mean to put that down. That's a big thing we need to be doing. But policy gets us to a systems level. And that's where I've become very passionate about policy. You've heard Lisa talk about ARP. There's stories I could share about our founder. I'm not going to do it right now because we've got to get to this panel. So let me just tell you that I think of policy from a nursing perspective. I consider it a nursing intervention at the community level. That's policy to me. It's true. And I think of it as it is an embodiment. Policy embodies our values as a society. It can be local, state, federal policy. And it can bring us forward or it can hold us back. And today, I've been hearing both. Policies that have held us back, policies that, if we can get them through, will bring us forward. And so I'm going to introduce this panel who is really amazing. They are smart, they're seasoned, they're passionate. I think some of them are very well known to members of this audience. And they're going to talk about how social determinants of health can address, how we can get policies to address this. So let me just quickly introduce them. I think they're waiting in the wings, I hope. And the first is Dr. Gary Painter, who's the director, USC Sol Price Center for Social Innovation, director of Homelessness Policy Research Institute. Here he is. Okay, so head on all the way down. And we have Dr. Clayton Chow, Agency Director, County of Orange Healthcare Agency. And here he is. And Michael Hunn, Chief Executive Officer, Cal Optima. There was just an article about him in Kaiser Health News. And Bonnie Preston, we're so glad Bonnie could join us, Acting Regional Director of U.S. Health and Human Services, Region 9. Thank you so much. So you know the drill. We're going to ask some questions, and you can use that scan, right? At questions of any of these speakers, you can submit them by using the QR code on the back of your program. That's what it says. So you know how to do it. All right. So Clayton, can I call you Clayton?
Of course, yes.
I'm glad.
They all know me by Clayton.
They all know you by Clayton. Is this
Yes.
working? Okay. So Clayton, there's this term, political determinants of health. And I've been saying social determinants of health, and there's social determinants of mental health. So how do these things differ, or how are they the same?
So the social determinant of health or social determinants of mental health are pretty much the same structural or programmatic barriers that led to inequity in health or mental health. There's a several point different as it related to general health and mental health, right? Whereas political determinant of health is a not so new concept. It's been around for about a decade now. But for those of you who are interested, one phenomenal book written by Dr. Daniel Dawes, and D-A-W-E-S, talk about the political determinant of health. These are the politics and the policy decision that would influence the social conditions that lead to bad or good health outcome.
You're nodding. You know these. You're familiar with that term, right?
Wait.
But I do want to ask you a particular question. You can certainly talk about the political determinants of health. But we were just chatting in the back room, in the green room or whatever they call that thing, that Bonnie has worked at many different levels in government. You could tell your story about that. But how would you describe the priorities, coordination, and cooperation, I guess, between local, state, and federal governments in addressing these health inequities?
Hi, everybody. Okay, can you hear
Yeah.
me?
It doesn't sound like
Up here, you can't tell. Okay. I was just nodding about the political determinants of health because, like you, when I was asked to be on this panel, I was not familiar with that term either. So I looked up and I ordered that book. So thank you you just sold another book for the guy. So really, really interesting. So in terms of, first I want to say in terms of today's topic in health equity, I would be remiss if I didn't just drop a pearl from my boss in DC, Secretary Javier Becerra, who has told everyone at HHS to really center everything they do in equity. And as you know, the Biden administration took office right in the middle of vaccine distribution in this country, and we're in a really bad spot in COVID where these social inequities that all of us who grew up in public health and work in healthcare, we saw people having the long-term effects of these policies and inequities. But in COVID, it was just very quickly, people were dying who were the most vulnerable. People who were in congregate settings, and also in multi-family housing, and who were our essential workers. So it was a time when the inequities were really in your face, and every night you would hear how many more people had died that day of COVID. And so the first day in office, President Biden put out an executive order on equity. And in that executive order, if you haven't seen it, I really encourage all of you to just Google Biden executive order health equity, because it's really very important how it's laid out. And he says that each federal agency will do an assessment of their policies and programs for how they affect equity. Are they equitable? Every federal program in the federal government is supposed to do these assessments and then make a plan to rectify those. So really from day one, this administration has said that it's going to be held accountable to equitable policies and programs. So that's kind of a backdrop for where we are now. And then in terms of the coordination in federal and local government, we can't, the COVID response comes to mind. And I think early in the response, FEMA was the federal agency put in charge of the response in terms of getting the vaccine out. And FEMA responded like FEMA does. I mean, like they would a hurricane. They were thinking of mass vaccination sites. Let's get the shots in arms. And that was very much a top-down federal approach. And one of our earlier speakers talked about early homelessness being seen as an emergency response. So there's some parallels there. So, but what was us in public health who were advising FEMA, we were saying, wait a minute, our most vulnerable populations, those people in nursing homes, these essential workers, are not going to come to these massive sites. They don't trust them. There were military people giving out doing the vaccinations. And, there was a large site at the A's Stadium set up, the Oakland Coliseum. And we went there with the county and their advisory board on COVID, which was made up of community-based organizations. And we walked them through, hoping that they would send their patients and clients there. And they're like, my people aren't going to come here. This is not. So this was a case where public health really had to stomp their feet, say, we need a different model. This is not working for the people who need the vaccinations the most. So was there good coordination, federal, local? Not at the beginning, but it evolved. So I think that's what tends to happen is there are things that evolve, problems, catastrophes, then there's a response that's done, and then we eventually learn that we have to look at what's the root problem that we're trying to solve here, and what's the best way to do it. So that's kind of a long answer to coordination. It takes a lot of advocacy on the part of those communities that are hardest hit.
And you're right in the middle of that, it seems.
We were right in the middle of it.
Thank you.
Who knew?
Who knew? Michael. So you're into healthcare plans, right? You got this plan. So what can plans do in terms of building equity in vulnerable communities in particular?
No, thank you. Glad to be here. Paul, I want to say thank you to you and the Illumination Foundation for putting this together. Really quite a marvelous event, and it's extraordinary to see a lot of people in one room. So nice to see everyone. No, now at Cal Optima, and I've certainly had a very interesting healthcare career, and now here on the Medicaid side at Cal Optima. From a policy standpoint, what can we do? And I think we can craft policies that touch as many lives as possible. Here in Orange County, Cal Optima has almost 900,000 members. That's 27% of the population of Orange County. There are 3.2 million residents in Orange County, and 27% of them are on Medicaid, Medi-Cal, through Cal Optum as the health plan. You would think in a county of our size, with the wealth that we have, that there wouldn't be that many people, close to 900,000, that need Medicaid assistance. That means a family of four making less than $38,500 a year. That means an individual making less than $18,700 a year. That's a lot of people who qualify. And so from a policy standpoint, what can we do to take the resources that we receive in premium dollars between the grants that come through the intergovernmental transfers, the IGTs, the funds that come obviously through the state? We get paid on a member month basis. So we have an individual, they qualify, they're on our rolls, and we get paid a monthly member amount. We then delegate out the network. We have 12 major medical group delegated networks of physicians. We have about 10,000 contracts in Orange County with providers, doctors, hospitals, clinics, diagnostic centers, et cetera, skilled facilities. And so we delegate that out, but we set through our board policy. And that policy says, where are we going to focus our additional efforts over and above the direct delivery of care by a doctor to a patient, by a hospital to a patient, or other services like skilled nursing? In that now we're looking at what can we do to address the equal access, the fairness and the levelness of access to other care. And that includes us addressing CalFresh, the old food stamp program. And we did a diagnostic lately, and we discovered on top of the 247,000 of our members that are on food stamps through CalFresh now and are eligible, we have another 344,000 that we think could be eligible. So now we're undertaking a full press court multi-language awareness campaign that our board recently approved. And so to drive policy, policy requires focus. Focus requires action. As I tell our team as the new CEO at Cal Optima, I am not here to admire the problems. And don't anybody confuse activity for accomplishment. And so I think when you drive policy, it's focusing on getting something done. And so I think when we look at social determinants, food insecurity is a social determinant. A lot of people don't understand the definition yet, and so I make it simple for those audiences that we speak to that aren't healthcare people. They're not in the business, they're not on the health plan side. And I go, where are you in your life right now? And are things good or bad? And do you have access to things that'll make you healthy and give you life, or you don't? That's social determinants.
That's great. You know, I'm going to take that back to the ARP Foundation. I don't know if they're here, because as Lisa was saying this morning, a lot of what they do is to get benefits to people. That there's so many people that are eligible for benefits that do not know about them or find a hard time getting them. And I like the idea of approaching the plans as a way to go about doing that. So thank you for the suggestion. That's great. So Gary, you spent a lot of time, I think, in thinking about the social safety net, as I understand it. But where are we with the social, is there a social safety net these days?
Well, I think that's a fair way to ask the question. And if there is a social safety net, who actually receives enough from our benefit and tax credits to actually sustain a lifestyle that, you know, would be equivalent to earning a living wage? And unfortunately, the answer is very, very few people, very few families get enough resources from the social safety net to support that equivalent of a living wage. So if I just just to give you a sense of this, if you are a mom with 2 young kids, it's possible. But how is it possible? Well, you had to have actually fallen into poverty so low that you qualified for our CalWORKS program in California, which has really stringent income limits and asset limits. So you had to be quite destitute. The reason that's necessary is that that's the only way to get sufficient child care subsidies to support you as you come out of that level of poverty. Perhaps even more importantly, that family is eligible for housing assistance, but more than likely they're going to apply and have to wait. What we know is that 1 in 5 eligible households get the housing assistance that they're eligible for, and therefore that scenario that I said it's possible, 1 in 5 if you got the housing, but you had to fall so low to get the child care necessary to support the resource base that you need that is equivalent to earning a living wage. That's not a rosy story, and that's why I think we're here today, because what we see collectively, and I just want to applaud everyone that came, because you're here because you actually want to end homelessness, and I again applaud the Illumination Foundation for their work in doing that. And so that's the small scenario, but if you start to peel back those layers, if you look at individuals, Medicaid is one exception to the rule where you actually can apply as an individual and get supported, but your earnings have to be less than $18,000. For most programs, you don't qualify for what you would, any of them, and so you actually have almost nothing available to you. Although immigrants in California often are eligible for programs, I'll use the term take-up rate as kind of what we're talking about, people who are eligible but don't receive them. Their take-up rate is much lower than people born here in the U.S. So you have programs like CalFresh, where the take-up rate for native-born households is above 70%. For immigrant households, it's closer to 50%. And so there's fear there. There's misunderstanding there. They know that in many states they're not eligible. They don't know that California is a place where they might be eligible for programs related to food, health, and housing. But I think just sums it up is that our safety net has 2 gigantic holes in it. Housing is a gigantic hole where most people don't get it, even if they're eligible, and childcare is a gigantic hole. As it relates to policy, the Build Back Better agenda did actually include fixing the childcare hole for working families. So you didn't have to fall all the way down to, receiving what the federal program, Temporary Assistance for Needy Family, CalWORKS in California. So that would have been quite helpful to fill that hole. There was slight bit of money allocated toward housing assistance, but nowhere close to universal housing assistance at the level of what a voucher gives, or even at the level of what a reasonable renter's tax credit could give. So right now it is a bit bleak with those huge holes there, and it matters.
Can I ask you, do you think that California is any better or worse than any other state in terms of the safety net?
I think because we actually do support immigrant families, it's a little bit better than other places. And I think we certainly have the resource base to think about what a universal housing assistance might look like for people who are paying, 50%, 60%, 70% of their income as rent. We could actually design and allocate some of the money that is going currently to addressing homelessness to actually then preventing homelessness.
Interesting, thank you. So Clayton, did you want to respond?
Well, I think my colleagues here gave you examples of situations or sets of benefit that people are qualified for, but very few of them enroll in them, right? It is because the policy that set the process of applying for these benefits is onerous, number one. Number two, if you don't understand English, or if you have a health condition that would not give you the patience to sustain this process, such as if you have mental illness or you have addictions or you have a chronic health condition that makes you tired easily, you can never ever get to the benefit itself. And then the last piece I would say is the education piece. Why is it that we have benefit but people don't understand that they qualify for it, that is available for them? And so you talk about accountability, but I think it's more than that. It's more than just accountability, but the enforcement. Who is doing the enforcement piece? We have had mental health parity law for a decade now, but does that really happen? You all know the answer to that, right? And so it is policy that set up the system that is that flaw, and we got to fix it, right? Otherwise, we will keep doing work around. Like, why would you have to spend millions of dollars to build billboards and to encourage people to apply for a benefit that everybody should know, right?
Yeah, I'll add a little more color to it. So as we launched this and started looking at it, I wanted to know exactly what the process was before we started. So I sat down with a social agency staff member and I said, walk me through the entire application for CalFresh and pretend like I'm applying. And I want to know exactly what it's like. So I did the staff orientation versus an individual. Just to get through the orientation of just the document itself was 2 hours. Okay?
Rest my case.
That's me orienting myself. An actual recipient, it's about 35 minutes, and they have to submit several sets of documents. The abandonment rate of those applying that kind of give up along the way, whether lack of patience, they get worried, or they have to actually produce a document that they can't, is about 40% abandonment. And in that process, what's the main reason? All of the requirements that go to these document submission and the answers to these questions for qualification are set by regulatory policy, not our policy. But despite that, I'm not going to back off on the commitment to make people aware of a benefit, because that means there are 60% who will finish it and find food sufficiency, hopefully, in the CalFresh program.
That's a good point. We yesterday went, right, Paul took us to a wonderful facility that the Illumination Foundation funds and delivers, and that was a big part of how to help people get the benefits and streamline it and have case managers right there on site. I think you said you could get it down to 3 weeks or so instead of months and months, so it is a huge problem. I remember in New Jersey, I was Deputy Commissioner of Health in New Jersey, and tried to figure out the Medicaid, as you're saying, the Medicaid process too. And this was particularly for long-term care. And a big thing was the life insurance policy. If you had a life insurance policy, do you know where it is? I mean, these are people that need long-term care, and it was just ridiculous. And every state is different, and we realize that too. So, I want Clayton, you started touching on mental health. And I wonder if you could return to that thought a moment, because you've got a lot of expertise in mental health. Is there anything going on around this country that excites you in mental health policy?
Well, so I talked about the parity laws, and I talked about the effort at the federal level is going on year 5 now to create the interagency coordinating committee for severe mental illness. And that was the federal government attempt to really bring all the agency who's in their own silos have to create mental health programs, right? Because it was just so desperate and separate that everybody realized whatever services that they provide, and you probably heard about it this morning, right? Whether it be correctional health or social services or what have you, housing, there's a need to create mental health program or program specifically target individual who utilize mental health services. And so there's federal effort to pull all of them together and said, have we been doing this in an effective way? Obviously, the answer is not. Not only that, we create confusion for people. And I've always joked about this, and that is every system you go through, they have a case manager to case manage their mutual clients. And that I've always asked, well, who on earth is case managing the case managers? Right? And so the fact that we have to have navigator to help people to navigate the system, it should tell you that there's something wrong with the system if you need to have navigators to help people navigate it, right? So instead of fixing the issue by changing policy, we now do workaround by hiring more navigators and put it on folks. And so if somebody who is clever enough to know the system, to navigate the system, and they will say, well, I have 5 case manager. If I couldn't get what I want from Michael, I'm going to go to him, and then I'm going to go to, you two, right? Then what do? We turn around, we blame people. We said, oh, they're manipulative. And I always tell my staff and my students is that is not manipulation. That is actually really good and smart because people learn to know how to navigate the system on their own. So don't blame the victim.
Right. Sort of like non-compliance.
That's
I hate
correct.
that word, non-compliance. Right. Bonnie, you're not getting off easy here. So you've done a lot of big things, right? You talked about the vaccination stuff. You've got big things going. But can you talk a little bit, some examples in which public health decisions and policies impact communities at a less big level?
Well, just I think in the time that I've been in healthcare, a lot of it's been about healthcare financing because we can't seem to get this right. So my example here would be, so I want to go to see a primary care doctor for a visit. And that service is going to be reimbursed differently if I'm a Medi-Cal or Medicaid patient or a Medicare patient or a private insurance patient. So we have the same service, but we have all these different payers that have this primary care provider has agreed to accept different payments for the same service. So that is just the flat example of structural, it's a construct, it's a policy construct that we have put together here, where is the provider going to look at each patient who's covered by a different payer equally? That's how we're set up, right? Mm-hmm. So, I personally think that's a big problem. So those are policies. We've agreed to have different people pay different amounts for the same service. We've agreed to that as a society. And so we have to kind of own up to that and say, are we going to keep it that way? Does it have to be that way? Does that make any sense? And so that's a policy that really affects how people are treated. Who's going to get better care from that provider? Even if that provider is like the salt of the earth, it still at some level affects you, especially at the end of the month when you have to make all your payments as a provider. So I wanted to remind people, in case you didn't know, when Medicare was finally passed by Lyndon Baines Johnson, he used that policy, and he turned to his Assistant Secretary for Health, who was Chancellor Lee from UCSF, actually. And he said, Phil, you know, I want to use Medicare to desegregate hospitals. Because there were some hospitals in the 60s that only whites could go to, or only blacks could go to. So Lyndon Johnson said, Phil, we're going to use the Medicare program to desegregate hospitals. So they did that. Mm-hmm. So if you wanted to participate in the Medicare program, guess what? You couldn't have a white-only hospital. So that's an example of a policy that was used to correct some inequalities. And then, you know, decades later, we finally get the Affordable Care Act. And that's what got me into the federal government. It was like the biggest thing in health policy in my entire career. And I had started quite years before, in the 80s. So I thought, okay, I want to go. I was volunteering to help sign people up for the Affordable Care Act. So they had these new positions in every region across the country for outreach people. So I wanted to do that. So we looked at the states and we said, okay, you know, states were in the lead, especially in California, because they set up their own exchange called Covered California, which was quite effective. But in the early days of signing people up, they were not when you looked at the racial and ethnic data, it wasn't, the people who were signing up did not reflect the racial and ethnic makeup of the uninsured in California. So we assisted Covered California in upping the enrollment among the Latino community and the Black community by turning again to our partners in the communities who were trusted, like nurses and doctors, to get them enlisted in signing up people for the Affordable Care Act. So that was a policy that was used to break down, you know, inequities in healthcare financing.
That's great. Thank you. Thank you.
Yeah.
So I'm going to turn to some questions from the audience. This one's really interesting, and any one of you could respond to it, or maybe more than one. Oftentimes, when organizations engage in equity efforts, their work is externally focused. In what ways have your organizations also engaged in internal organizational work? What concrete actions have your organizations taken beyond DEI commitment statements? Michael, maybe you first?
Yeah. No, we have a workforce of about 1,560 individuals, including our teleworkers as well as our part-time folks that come in and out. We've done a number of things on the equity. We are very multicultural and multi-ethnic and multilingual, as you can imagine, because we serve that same client base. So we have all 7 primary languages in our building. As part of that, we also have a benefits package that's equal to all. And recently we did a review of our salary and wage scales to make sure that we didn't have anybody below a certain threshold, and making sure that that's fair. And that includes both male and female. And so when we look at things, we don't look at it just in terms of what the policy says, but what is fair and does it look correct? And if I were to assess it, does it make sense? In addition, there are those that are in our employ that are also struggling, right? Not all employees life is good. It's not that way at all. And so we're beginning to recognize that we have to do our own social determinants of health assessment of our own employees, because we have some that have life circumstances that have led them to be in very difficult positions. And we need to be attuned to that and offer a doorway for them to be able to go through without fear, without stigma. As you know, that's a big deal. And whether that's behavioral health issues or life issues, we're making that a very concerted effort among our employees with our Human Resources Department.
That's great. Thank you. Clayton?
So I think that question might have come from one of my staff to remind me to talk about this. So Orange County, the health agency, we receive a population health and equity grant from the CDC. And in the next 2 years, what our attempt to do is to really create an infrastructure within the community to do this kind of work, especially to build infrastructure for small CBO that historically have not had the ability to contract not only with the county, but with foundations or other grantors. And so that's one goal. And the other thing is to work together with a large health system here in Orange County, the Kaiser, the Providence, the Memorial Care, et cetera, to really focusing on aligning our policy and funding to laser focus on 3 social determinants of health that is determined and driven by the community. So we're in the process of doing that. But most of those work are outward, right? So you can't do things to the community without reassessing or assessing your own agency on where you're at as is related to JEDI, justice, equity, diversity, and inclusions. And so we've contracted with IHI to come into Orange County to, number one, not only help us facilitate this conversation in the community, because somebody brought up the issue of trust, and we realize that that issue of trust it really is the basis of how people access care and services. Is it the government? Is it big health system that are not culturally inclusive historically, right? And so we want a third party who has international footprint to come into Orange County and help us drive and facilitate that work. And then we also work with IHI to really do the assessment of JEDI within my agency as well.
That's really advanced. That's great. Gary, I wanted to ask you a question, and then I'll return to some of the audience, because we haven't talked about this yet, social innovation. And I think this is something you are an expert in. If you could tell us what is meant by it and why it's important.
Well, I hope so, since I'm a director of a research center on social innovation. If I can't tell you, then no
We're in
one
trouble.
can. I guess the analogy that I would give just to begin is just, we have in the private sector, we have a way of going about when we have a complex problem, we know how to deploy resources to innovate. And we didn't 150 years ago. You just had the Thomas Edisons, you had the Alexander Graham Bells that were sitting in labs kind of doing it on their own. We're in a space in the social sector where we have a lot of people doing it on their own, but we actually don't have an infrastructure to deploy resources to allow innovation to happen, to address complex problems. And so the definition is that social innovation is an iterative and inclusive process that intends to generate just and effective solutions to complex social problems. And so you can think about what we did when COVID hit with the vaccines, is that we actually had a way to say, okay, here is the DNA or RNA of the virus, and people in various pharmaceutical companies around the world could just plug it in and say, we're going to spend a bunch of money, and we expect that the first 50, 60, 70 vaccines we try will fail, but we're going to keep innovating and learning and learning and learning. We don't do the same kind of thing in the social sector to solve complex social problems, and homelessness is absolutely in that category. A lot of our complex problems are of our own doing, right? So we've made policy choices to actually separate, exclude, make things more difficult, as has been discussed, for people to navigate when they do fall down, to actually get back up. We make it pretty hard. And so I think what we need to do is to say, if we have such a problem, are we willing to deploy some resources to generate and co-produce new ideas, to rapidly learn by testing early innovation, kind of what I call early innovation pilots, where you're just trying to figure out, is anything happening? Perhaps in the medical field, the analogy is a dose response, a phase 1 drug trial for people who are in the health field. Then you start to do proof of concept. But again, you anticipate that you're there to learn quickly and go back to the drawing board, and including a broad set of stakeholders to co-produce those solutions. Ultimately, by including people with economic and social power, with people who are in the community that are experiencing that complex social problem on a day-to-day basis, there is the chance to really see systems change. The book that I'm working on right now is called From Disruption to Diffusion. How do you activate the process of social innovation? And I think that sometimes people think about in the social sector, I don't want disruption, because they hear a Mark Zuckerberg talk and talking about, he has all these, analogies that kind of we cringe with, the break a few eggs to make an omelet sort of analogy, or, those kinds of things don't sound right in the social sector. However, the place we're at now is not just or effective. We actually do need to disrupt that. And so we need to create a process that does it, that can lead to those solutions. So that's a primer. I'm happy to talk to others. Please look me up. And, it's certainly my passion.
So when is your book coming out?
Well, I'm hoping to have it complete in the fall, and then it'll come out the next year.
Right.
Yes.
For Christmas or any holiday. Great. Okay. So we have this is a very interesting question from the audience. How does politics contribute to or detract from health equity? It's a loaded one. Anyone want to take it on? Okay.
So I'll head off on this one. But to finish up where you were, Gary, one of the things that we're doing right now with Illumination Foundation and Paul's team, we've decided as a policy decision at CalOptima to proceed to grant 15 days of presumptive eligibility for any individual that could benefit from recuperative care services.
That's fantastic.
So, having been the past board chair of the National Health Foundation, of which one of their largest service lines is recuperative care, and serving on the board and as board chair, I understand the recuperative care space incredibly well. And as part of our work in going and visiting Paul's site up in Fullerton with his whole team, what they're doing is extraordinary in being able to work with individuals, but the policy needed to be changed. We had offered 3 days of presumptive eligibility. And when I arrived at CalOptima and looked at it with our team, it's like, this makes no sense to me at all. So I went to the board and explained why it didn't make sense to me, either socially or clinically. And they didn't disagree. And so we changed it. Now Paul and his team have up to 15 days to get an individual on the runway of eligibility. And that includes not only Medi-Cal, but also other programs like CalFresh, et cetera. It gives them enough time to actually get the assessments, get the documentation, get the family involved, work with the individual, and get that individual on the runway for some sort of takeoff. But without that time, I think that has inhibited the number of individuals that can actually be helped. So when you look at how can politics help, any board has a political element to it. I don't care what board it is. Every board has a political element to it. And when you work with management and clinical and operations, and you put rationale to the idea or to the thought, and then you present that to those individuals because they all are independent. We're a public agency, so we're bound by the Brown Act. I have to talk to each board member independently. I can't disclose what any other board member said about what any other board member said. And in the end, they have to make a decision in an open public meeting. And so the way it works politically, I think, is that if you make a compelling case, I think you'll get a good answer. And in this case, I think, Paul, this was a good one. And I think this will benefit a lot of individuals. So that's how I think politics and healthcare can go well together. Now, not everybody always agrees, but that's an incident where I think it is working, and we're looking forward to the results because this just happened recently.
Congratulations. That's fantastic. Did anyone else want to respond to that?
I'll just say one thing, just to be, provocative. So, who here thinks that the Illumination Foundation should pay more for healthcare than Twitter?
Seeing any hands up.
I suspect there shouldn't be any hands up, because it is the case, right, that nonprofit organizations, small businesses pay a lot more for healthcare to provide healthcare for their employees than corporations. And you're talking politics. Well, corporations, the large corporations, don't want to lose their advantage. attracting the best employees by providing them the best health care at the lowest cost. And so, in my view, I'm in a public policy school, so we talk about such things, although I don't know anything about health compared to my panelist here. That's just simple political and economic power at work. They want to have the cheapest health care to attract the best employees, and that disadvantages nonprofits and small businesses. Simple as that.
Provocative? Yeah, okay, good job. So here's an interesting one for you, Clayton. I am an LVN, that's a licensed vocational nurse, that is working in mental health, and I will soon have my baccalaureate degree in nursing. How can I help? Where should I start?
We are hiring as we speak.
CalOptima.org.
Work to us.
CalOptima.org.
Don't listen to him.
Use-
the healthcare agency family is
use
huge
Michael
with a lot of
Hunn,
support.
Hunn, as your reference. See me out in the lobby.
He forgot that I sit on his board. I might have to flex that muscle. But no, I think the time is right for people to go into healthcare, because we do know that there's a shortage of healthcare professionals of all type in this country, particularly in the mental health area. If tomorrow every single Americans who have mental health needs raised their hands and said, I want services today, we will be in deep trouble. We don't have enough mental health professionals. It is to the point where here in Orange County, I was just informed that there is a psychiatrist here, cash paying only, 50-minute intake is $850. Okay, so Bonnie, I don't think I think the issues with the policy, and I think the differential payment should be based on quality of care and not so much of access to care, right? Because access to care means if you're able to pay higher, or if your insurance pay higher, you get to be seen quicker.
Right.
That is a policy flaw. People need to get treatment based on their clinical presentation and urgency and emergency, not based on how much the insurance company pay the provider for.
Yeah.
You want to take that on, Bonnie? Anything?
No, I could not agree more. And I think we would spend a lot less on quality assurance, because you wouldn't have different payers having to look at their own individual circumstance and vulnerabilities.
And we can do this. Oh boy, I think I'm going to get a pink slip tomorrow. And that is, we have to, and someone in earlier panel talked about this, we have to look at the reimbursement process. Why would a primary care physician get paid much less or get reimbursed much less than a plastic surgeon or an orthopedic surgeon?
Right.
That makes no sense to me.
Yeah. People have talked about the amount of time.
Not many of you agree with that point, or? So we need to relook at that, right? Because we need to value the work of the primary care physician or the primary care nurse practitioner and what have you, right? Where I came from, I grew up with the care of a nurse around my neighborhood. That's the concept. We have to go back to that, right? So.
Also, when I started in public health in San Francisco in the Department of Public Health, there was a category of work. There were community health care workers. People started as a community health care worker. They worked their way, and we had them then in the planning department. So, it's not a new concept. We're trying to rebuild and go back to what we know works.
Back to the future.
Yeah.
So we have about 4.5 minutes left, and I have this question that I think it's rather intriguing. Within a capitalistic economy, can we ever achieve true equity, or is inequity an immutable byproduct of capitalism?
So first of all, to answer that question, we all have to agree that in this country, healthcare is a business.
Yes.
We have to accept that fact.
Anyone disagree? No. You got them.
If we don't accept that fact, we cannot move on, right? You all have this statistic in terms of the developed country. Our expenditure in healthcare is one of the highest, but our health outcome is one of the poorest. And that is because of the silo things that are driven by policies that really doesn't pay attention to the vulnerable population. That's the problem. If you are vulnerable and you have multiple chronic health conditions, including mental health condition, including addictions, how is it that a primary care physician can take care of you with a 5-minute visit?
Right.
Answer that question. Right? So if we accept that healthcare is a business, and in this capitalistic world, the payment, the reimbursement should be based on the quality of care, not based on how many patients can you see. Because that's the problem with managed care, is I get paid $10 a month whether or not I see Bonnie 0 times or 10 times. There's something wrong with that.
You want to take that on, Michael?
Yeah, I'll add a little thought to it. So,
Remember, I'm sitting on your board still.
I know. So, Director Chow.
Yes, CEO Han.
So, I started out as an intake director in drug and alcohol. It was my first job. I answered an ad in the San Diego Union Tribune. I showed up to work first day. I didn't even know how much I was making. It was $25,000 a year. And I had just recently had left the priesthood and got my dispensation from Rome and all that good stuff. And the guy that hired me said, I'd like to hire ex-clergy because you're compassionate, you're nice, and we think you work really well with drug and alcohol folks. So I started the job, and I learned very quickly, had dealt with a lot of alcoholism in my years. But over time, I worked for a for-profit company, and I didn't like it because they were more concerned about getting them in than they were about getting them healthy. I've worked for large multinational companies. I've worked for national companies, for-profit. I've worked for not-for-profit healthcare systems. Most recently, I led the Providence Health System in LA till a few years back. And now recently coming back as a CEO, which I had no plans or intentions of doing. But here at CalOptima, because of this vulnerable population. So when you look at the corporatization of medicine, and I've seen it over a decades of my healthcare career, 35, 40 years now at this point. And at age 66, I look back, I'm now on Medicare. So I have a real perspective on the for-profit versus not-for-profit and the equalization of the delivery of healthcare in an equity model that allows an individual to get the right care at the right price point at the right time, navigated in a respectful and dignified manner. Regrettably, we don't quite have that yet. I don't know if we can boil that ocean in our lifetime, but I can say that at some point, the tipping point economically will come, and then system and political and policy will change. We're not there yet, but are there inequities? You bet there are. Is there healthcare rationing? Every single day in this country. My background is biomedical ethics, so from an ethics standpoint, I look at it and I say, will we ever have that equity and that evenness and that fairness? I hope so, but I think it's a lofty, lofty, lofty goal.
And that's the last word, because it's 000, no time. But please join me in thanking this fabulous panel. Thank you.
Moderator.